Very well, it's time for your health segment, and today we will be focusing on affordable healthcare, and specifically we will be looking at emergency care, given that statistics indicate at least 54% of deaths that occur after an accident could have been prevented. And how could that have been done? It's by accessing emergency care, and we will be looking at what really can be done and what are the challenges that we face, and what do we mean when we talk about emergency care? Is it the first responders on the ground, or it goes beyond that? And for more answers on that, we are now joined by Dr. Benjamin Wachira, who is an assistant professor of emergency medicine at the Aga Khan University, as well as Dr. Jeremiah Njenga, who is from the executive director at the Emergency Medical Kenya Foundation. They will be giving us more insights on what exactly is emergency care and what is it that we can do to be able to improve that. Gentlemen, thank you very much for coming to our studios.
Thank you.
I don't know if you're football fans, but we appreciate you finding time to be with us here today. So I'll begin with you. In terms of painting the picture for us, what do we mean when we talk about the status of emergency care in our country?
So as we speak, the biggest challenge we have in our country is that, first of all, there is not so much data that is collected in this area of emergency care. And you realize, like, the data we have is mostly, like, for example, when you talk about road traffic accident, that is mostly through the National Transport and Safety Authority, that's the NTSA. But there are also other emergencies occurring. And the other challenge we have with getting data is that actually most of our hospitals do not have an area where they call an accident and emergency department. Most of them will actually have an outpatient department. So getting data is one of the challenges we're experiencing. However, as a foundation, that's one of the gaps we're trying to fill in. And we start collecting data so that we're able to tell what exactly are the emergencies that we get. Further to that, we know there's already data that has been from the mortality that occurs in the hospital. We're able to tell that of the 10 topmost causes of death in our country, most of those are preventable deaths from emergency care that the patients would have received.
All right. When we talk about emergency care, what are we referring to? Is it the first responders on the ground? Is it the first aid that we give them, or what?
So essentially, emergency care is a care that anyone who falls acutely ill or gets injured receives from the point where they get injured. So it could be in the house, could be in the home, in the office, could be here, where from that point, the care that the patient provides or the person gets from that perspective, all the way into the hospital where they receive emergency medical treatment in the emergency department. So it's that life-saving care that, if not provided essentially within what we'd potentially call even the golden hour, then the patient will either die or suffer permanent disability or have a protracted hospital stay unnecessarily. So it's that acute care that patients get.
So how do we change that?
So the key thing is, the biggest challenge that we've been having a lot is, for many years, emergency medicine has not been recognized as a specialty. Even right now, the pre-hospital providers, that's the EMTs, are still not recognized by the government bodies as healthcare providers. So the whole emergency care spectrum has been a big gap. And it's only until the last couple of years that we've really had a lot of traction happening in terms of developing emergency care, with the recognition of emergency medicine as a speciality, the government putting in emergency care into the Constitution in 2010, the Health Act in 2017, and there's a policy coming in on emergency medical care from the government that also addresses emergency medical treatment. So there's a lot of work over the last, I'd say, 5 years that is looking to improve the emergency care system, because for many years, as Jeremy was saying, many people are dying. Even now, many people are dying because of the lack of a system. So all these structures have started to be put in place to generate this structure to improve on emergency response in the country.
So Jeremy, in terms of, the bottlenecks, what really are the issues that you've identified that you need to fill, the gaps that you're talking about?
So as Benjamin was saying, the first one is the training. So you find, as you're saying, most healthcare providers do not have the necessary skills that they need. And this is a gap that we see right from medical school. Our training, we rarely go to the emergency departments to get the training. We are used to being trained with a patient in the ward. And then when you go out there, you're put on the front line. So that's where the gap starts. And we are engaging the universities that they need to change this, and they need to expose students more to emergencies right from the time they're in the university.
So is it part of the syllabus?
So that's one. I know that's going to take a while, but we are starting slowly. But that's one of the gaps we're identifying. And we are coming in as a foundation, trying to see how we can help bridge that from the training that we have acquired ourselves. Yeah, right. That, and then also to do with the facilities that are currently there. The one thing we are noticing is that actually we have most of the equipment that are required, and we know recently the government sent in a lot of money and equipment were bought. However, you find also as the equipment is there, sometimes the individuals to run the equipment are not trained. So equipment may be there, some of it is lacking, but also the equipment that is there, we don't have people who can run the equipment. Yeah.
All right, so in terms of statistics, are there any existing doctors who are specializing in emergency care? Do we have nurses in this field?
So for doctors, I think what we have an emergency physician who's trained outside the country and currently working in the country, but we have more that are coming in. At Aga Khan University, we started a postgraduate training program for doctors to train in emergency care, and that has been running now since 2016 actually. So we've had a few graduates. Jeremy actually did graduate from there also. That now coming out to help in the practice on the ground. For nursing, they've had emergency nursing at Kenyatta National Hospital and Nairobi Hospital for a couple of years. Though some of the challenges is we train very well, we train a lot of good nurses, but unfortunately they leave the country for greener pastures, which is also a big challenge locally. Kijabe Hospital did start a postgraduate training program for clinical officers in last year. So there is actually a couple of programs that are coming up now to try and fit the gap. But in total, we are probably, if you add plus the EMTs, they're probably less than 2,000 trained healthcare providers, ranging from nurses.
Is that spread across the country, or you're talking about Nairobi?
Mostly Nairobi. So most of the nurses and the doctors and most of the nurses and doctors and clinical officers are within Nairobi. EMTs have a few pockets, even in Kisumu, in Nakuru, there are EMT training programs there, but we are still stuck in Nairobi. So there's a big gap outside Nairobi.
And now that we are moving into devolving healthcare, affordable healthcare at the ground, how are you hoping to change this? Because if we're talking about, it's not like emergencies only happen in Nairobi.
So one of the projects we are running, we're actually calling it Project 47 as a foundation. And we're actually going out to the field. We've already engaged about 10 counties. And the first thing, as we say, there's no data. So we are actually identifying these emergency departments, actually to know where they are located. And then we do we actually geotag them. So we know this is all the areas where the emergency departments are. And then the other thing we are doing is, apart from that, we're evaluating the emergency departments. We know what are the gaps, what are their strengths. So that will give a roadmap to the counties when they're developing the emergency care. And then on top of that, we are going ahead and training on ECG. ECG is the one that is used to diagnose heart attacks and other conditions of the heart. So that they're able to do that, and also a vital signs monitor we give them. One of the things in the country, there's no triage system, especially for adults. So we teach the nurses on how to do this triage, so that patients are seen not on a first come, first seen, but based on their acuity or how sick they are. Yeah.
All right. In terms of an emergency center setup, what should be there? What is expected to be found in such a unit, and do we have those many in this country? So
essentially, emergency unit should be able to acutely receive a patient, stabilize a patient, provide all the life-saving interventions within the department. I think the only thing that I would say that is not possible to be done within the emergency departments, maybe an operation, theater, take you to theater. So in terms of being able to put you on a life-saving machine to help you breathe, in terms of being able to give you drugs when you're having a heart attack, when, for example, someone is choking or even someone is having a fit, being able to stabilize you and put you on monitors, being able to pretty much stop bleeding, acute bleeding. So in terms of equipment, there need to be monitors, there need to be ventilators, ultrasounds, point of care ultrasounds, equipment where you're actually able to quickly tell if someone is bleeding internally at the bedside. Immediately the patient comes in, you check if they're bleeding internally. So saves that time for you to get to the theater. ECG machines, as Jeremy said, which check if you're having a heart attack. So these are things that need to be diagnosed. They are time sensitive. The biggest issue with emergency kits is time sensitivity, where if you delay, people die. So that's the biggest challenge of, and some of this equipment exists. For example, we have, Aga Khan would be potentially a model emergency department, and many private facilities do have some of this equipment, but a lot of this equipment is still lacking in the public sector, and there's a need to improve on the availability of some of this equipment. It exists, for example, you get an ECG machine somewhere, an ultrasound machine somewhere, but creating that center where patients can come in and get their conditions acutely diagnosed and stabilized, versus where you come in and just sit and wait and there's a delay. I mean, we've had so many stories through the media of where delayed care was provided and people die. Yes.
So in terms of ambulances, because I'm also trying to think around it, do they have the equipment to perhaps, give the emergency care?
So there are different levels of ambulances. And we have ambulance standards that were developed by the Kenya Bureau of Standards, which has been in the media, but unfortunately they have not been really well implemented. So the ambulances range from well-equipped ambulance, intensive care kind of ambulance, that have all the equipment that we have in the emergency department is in the ambulance, because it's all portable equipment. But then we also have the vehicles that only have a stretcher and a siren. So the range, and part of what the studies that we have done is to also try and assess some of the ambulance services. And I think, Jeremy,
so do they need to be uniform, or the classification is fine the way it is?
No, there needs to be a uniformity in the ambulances. If you're a basic life, so there'll be basic life support ambulance or advanced life support ambulance, and the equipment varies between the two. And there are standards available through KEBS, so it's already been agreed upon.
Jeremy, in terms of access to emergency care, how accessible are they? Because most of the times you'll hear people talking about, they were rushed to hospital, and they start being asked about, do you have health insurance and all these kind of things. So what is the criteria when you need emergency care?
So that's one of the challenges. In that one, in the country, we don't have a universal code. And the one that exists, most of the time, people have said you'll call in, you don't actually get help. So that's one of the challenges. So when people get into an emergency, the first thing, and we usually ask, even when we're doing our trainings, like even here, I don't know how many of our viewers know of a number they can call, and an ambulance will actually come and help them. Most people don't have those numbers. And that's one of the challenges. The other thing is that most people either call their neighbors, a relative. And you see, for an emergency, as Benjamin was saying, time is the most crucial thing. And we have this golden hour. If you don't access care within that 1 hour, especially trauma, then that means your chances of survival keep getting worse and worse. So that's one of the biggest challenges. And then to add on to that, some of our facilities, and that's actually what we're doing, we're trying to assess what are these facilities that are able to give you that adequate and effective emergency care.
All right. As we wind up, tell us about the policy that you're set to launch, 2018-2013 emergency medical care policy.
Yeah. So various organizations have been involved in the development of a policy with the Ministry of Health, the Emergency Medical Care Policy 2018-2013. So what happened is 2010 there was the declaration that every Kenyan has the right to emergency medical treatment. And then came in the Health Policy, Health Act in 2017 that also really emphasized the need for every Kenyan to receive appropriate emergency medical treatment, and actually went ahead and defined what is this treatment, and also created a provision for the development of an emergency medical care fund. So the Emergency Medical Care Policy 2018-2030 essentially is tailored to now go into more details based on all this legislation that exists to explain in details how this should be done. And I know ministry has been preparing it, and it's actually due to be released soon. I'm not sure exactly of the details when, but ideally it will lay out in more detail what is required, because part of the issue is many counties actually were asking is, how do we develop this? There were no guidelines on how to develop emergency medical care. So the policy really will help the counties in terms of addressing their kind gaps and also being able to have a framework for developing emergency medical treatment.
In terms of, cost implications based on what he's saying in the policy, given that it will also capture, county governments, how tenable will it be in terms of setting up an entire emergency care unit in each county?
Well, it will cost some money, especially when it comes to the structure. But one of the things that we are doing is that we are assessing whatever they have. And we are trying to tell them the first thing they need to do is to start where they are. Like, they should allocate a room for acute care. So, meaning that they don't need to necessarily build a new one. They just need probably to create room. So,
will they get the personnel to sit in the room?
Yes.
So one of the things we are doing is we are trying to build capacity. And we are encouraging counties for every, that one of the things they do is that they rotate their staff. So we are saying, could you keep this staff like permanently in the emergency department, so that when we come, they're able to keep, every time we do a training with them, they're the same group, we continue enhancing, and within a few years, then we'll have people who can actually do the emergency care. So the staff will actually be there, and then slowly they build now on the infrastructure, because that's a major cost. The infrastructure is a major cost. But apart from that, the other things, most of the staff are actually there. What they need is just reorganizing and the know-how, because that's what is actually lacking. Yeah.
All right. In terms of what will it mean in the event that, we set up this emergency care unit, what will we be looking at in terms of saving lives as we wind up the program?
So I think the first part of it is with everyone knowing where exactly is their closest emergency department, then that means they're able to access it in a timely manner. And if we develop departments that on a regular basis handle emergencies, then they get good at it. And so that means we'll probably be able to intervene early to reduce morbidity and mortality for the patients. And based on a lot of studies and for countries, actually, I think Rwanda did start an emergency medical training program, and they did some data on one of the emergency departments. And interestingly enough, they were able to show a reduction in hospital mortality by up to 50%, meaning half of the patients who previously were dying are not dying now, but just simply instituting an emergency department. So we have actually studies that have been done within the context, our similar context. But if we actually go down to the ground and start implementing some of this, then there's a potential of saving many Kenyans' lives.
Jeremiah, your last words as we wind up.
For us is that I'll tell every Kenyan that emergencies do occur every day, whether we have systems or not to take care of them. We have our symposium that is actually going on this Thursday and Friday. So people should come in and hear more and actually get to catch up with more emergency care providers in the country. Our theme is World of Emergency Care, so we're able to see what else is happening outside. So
in terms of, in this policy, how many people are you hoping to have trained by, 2030 to be able to respond to emergency care? Because you talk about 2,000.
Well, I think the thing is, if you have specified, I mean, every county needs on average maybe 5 to 6 emergency departments. Not every facility can provide emergency care.
So how many people should be in each facility?
At least, if we were to say 10 people per emergency department, doctors, nurses, clinical officers are trained in emergency care. So then that would be a very good start to be able to stabilize the system.
All right, gentlemen, unfortunately, we've run out of time, but thank you so much for finding time to come and explain to us what really this means for us.
Okay, thank you.
Well, we have been talking to Dr. Benjamin Wachira, the Assistant Professor of Emergency Medicine at Aga Khan University Hospital, as well as Dr. Njenga, the Executive Director at Emergency Medical Kenya Foundation, putting into perspective all about emergency care and some of the initiatives that they're undertaking, trying to ensure that they empower both the national and county governments to be able to respond to some of these emergencies very fast, given that it is crucial. The first few minutes determine whether you live or not if you're involved in any kind of accident. This is where we put a cap on your health. But business news is up next, so stay tuned.